Welcome to the What About Rural Health podcast, a place where research, policy, and real-life stories come together to ask the critical question, what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers working miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Thank you so much for that response. I really do agree with you. And I know Kukuma Camp last year, I had humanitarian response that had come to me and say, we're trying to bring innovators to spearhead different kinds of interventions within the camp that would allow for offsprings of the parents, like the people who came in and have children there, to have alternative, they call it alternative education, where even though the camp is not sufficiently helping, is not sufficiently a formal way of education, but there's a program that UNCH, oh my God, I don't know why I'm missing that acronym, created, that if you go through an educational system, you can be able to write a higher level examination that allows you to get into college. So they were calling innovators around the world. And at some point I had, a couple of conversations with them, but I hands off because I told them, you have so much expertise on ground to do that. You don't need me. So I agree in seeing ways, instead of rolling back things, how do we progress solutions towards self-sufficiency, self-reliance for refugees, so that either they choose to go back or they choose to settle in where they are now. They could be able to, like, when we talk about the right to work, it's something that gives you prestige because, I've got a right. So I'm going to go seek a job that I really enjoy than a work to survive that most people do, where, you are conditioned to work as a requirement to remain here. Then you don't have a choice to pick and choose where you need to work. And many of them have advanced degrees that they could be far more useful to the economy than packing meats. Yeah. But because that's the condition to remain, a refugee, they just go do that. And, this also lead me to bringing back the question home, because we've talked a little bit across the world. And I want to come down to US, refugee resettlement system. Because this conversation about the American dream, and I think many people always assume that when refugees arrive here, there's a fully support structure in place. And once they land here, things like housing, healthcare, education, and employment are handed off to them. Not just the locals, because, locals have this notion that when refugees come, these things are handed off, especially those in communities where they don't have these things easily. But also the refugees, some of them, like the American dream, if I just arrived safely in America, all my problems get solved. But you and I know that that's far from the reality, So could you walk us through what this system really look like for those who want to learn about how the U.S. resettlement system look like before everything went haywire, and what were the biggest challenges, especially with folks that are getting placed in these rural, peripheries?
Yeah, thank you for clarifying the end of the question too. Well, the temporality of this answer is important. Everything I can tell you was in place before the current administration. It's not clear yet. Really, it's not clear. The stop work orders, the executive orders that have happened since Trump took office don't create a lot of clarity for how things work now. And it's also, we still are acting in this country under the guidance of the 1980 Refugee Act. That law hasn't changed. Congress hasn't changed the law, but all of the programs are not operating the way they should be. So let's talk about before Trump upended the entire system. I think it's interesting to think about what we'll rebuild, but when refugees arrive, it isn't untrue that they have a lot of resources devoted to them when compared to other migrants who might arrive, other newcomers. If you come across the southern border, for instance, of your own will, looking for a job, even if you have paperwork to do so, if you're on a work visa, if you come without paperwork, you don't have anything on this end. You sort of have to figure it out. You don't have access, right? If you get asylum, that's a different story. Then we're talking more on par with what refugees get. But if you're here to work on a visa or without one, you just have to make life happen. If you come in as a refugee, you are assigned to a local refugee resettlement agency by the federal government. So the government partners with nonprofit organizations that have offices in local communities all around this country, all around the country. So in rural areas, in urban centers, really spread all around in almost all of the states. And if you're assigned to one of these communities, you don't have a choice. You need to go to that community. That's literally where the plane will take you. You get met at the airport by somebody, though. That person takes you to a new apartment that's been set up on your behalf. You didn't decide where to live, but there's an apartment there and the rent is paid. There are chairs and tables and beds. There's literally a list of things that the State Department provided that refugee resettlement agencies have to provide when newcomers are going to arrive and be in the care of that organization. You then are assigned a caseworker who's supposed to help you find work, get your children enrolled in school, figure out daycare with you. You might have had access, you used to have access to some refugee cash assistance, or if you have a family, to TANF, on par with what anyone else eligible for TANF would have gotten, the same numbers, and refugee medical care. So refugee medical assistance, RMA, is over now, I believe, but it is literally access to the same things you get if you got Medicaid or Medicare. So there was quite a lot of entitlements. How they're taken up, again, depends on implementation and the challenges of the local community. But I think it is true to say that if you look at immigrants coming to the U.S. who have no help, no access to resources, or just the social networks that they are lucky enough to be associated with, or a refugee community, the disparity appears to be quite great. One of the major differences is that when refugees arrive, they also are given a work permit. Again, the responsibility to work. So along with all of these resources, refugees are one of the most scrutinized populations, other than the incarcerated population, in the country. These agents of the state, right, these nonprofit workers who are employed to operate federal policy, are supposed to be required to be in your home, making sure you know how to use the sink, making sure you know how to turn on an oven. I mean, it's so paternalizing, it's out of control, right? Making sure you know how, and also could be helpful for some families to know how to get on the subway, right? How does the metro work? If you're in a rural community, though, figuring out how to get to the job, because you might be 20 miles from the job and there may be no public transportation. So having a caseworker sort of help you figure some of these things out can be really helpful, but you have this responsibility to work. And at the same time, you might be first concerned about your health needs, the mental health care needs of your children, getting your children in school. So it's not untrue, right, that there's a whole bunch of resources for these folks. I think that the biggest challenges in rural communities include that not every community is as welcoming as the one I talked about earlier in our example of the meatpacking plant. So you might have a community that is quite xenophobic. Where the racism is either quite evident or subtle, but either way, it makes a very unwelcoming space to be a newcomer and hard to find belonging. There are also an incredible dearth of mental health resources everywhere, but for sure in rural communities, and ones that are actually culturally aligned with the background of any newcomer that comes from. Think about the kinds of things that happen. We have all of a sudden an evacuation from Afghanistan. The idea that if anyone from Afghanistan got resettled into a rural community and there would be a Pashto-speaking mental health provider who understands the needs of this community are pretty small. So similarly, depending on where people arrive and where they land, there's a very small likelihood that there will be a grocery store with appropriate foods that feel familiar, right, and that are suitable for your body if you don't have a corn-based diet, as we do in the United States, but instead come from a healthier diet of, say, rice and greens, but they're harder to find in the way you're familiar with in rural communities. So all these social determinants of health, right, access to the sorts of things that keep you healthy, can be a real challenge, as well as then if you do get sick, finding healthcare that's appropriately aligned and culturally aligned so that you feel you want to go get healthcare. Do you want to see a doctor if you're someone who, again, is from Afghanistan and you're a woman? What if the only doctors that you can find are men?
Thank you for that response. And while you were talking, I remember I've gone to, I think 2 summers ago I can't remember the name of the place, but it's in North Carolina. And when I came into that neighborhood, the first thing I saw there is everyone is welcomed here. Black, white, it's like a full list, color, this, that, white life matter, black life matter, color life matter. It was just so much. And it's like, as long as you are a human being, you're welcome to this community. And it also had that welcoming ambience. And I stayed there maybe for like 2, 3 hours, walk around because I like to walk when I travel to new cities, walk around, take a couple of pictures. I'm like, why won't all places be like this? And that brings me to my question that I wanted to ask you, because there are also communities that are quite welcoming but have limited resources. And the level of support that they could give to refugees are very limited. For instance, when the communities do not have social services who can provide interpretation, or that their own social system is already overwhelmed, how do you think that in situations like that, that the refugees and the agencies that support them navigate this tension?
I think it's a really great question. And one of the things we have to resist, as I'm thinking about your question, I'm thinking about how easy it would be to slip into generalities and yet how unhelpful that is. So I'm thinking about some, individuals who I've seen in their service delivery experiences who are just so angry to be here. They're just so angry. I'm thinking about this individual, this man. I just felt so deeply for him. He kept saying, "You bombed my country. I didn't ask to be here. And now you're not even giving me what I need." He was at the doctor and he was in a good deal of pain. All he wanted was some medication, but the insurance wouldn't cover the medication. And he was just so angry. He just wanted to go home. There's a really incredible book by an author, Dina Nayeri, called The Ungrateful Refugee. And I think it's part of what I'm thinking about in answer to your question is what happens when, this refugee who's living in your small community that already is maybe resource deprived doesn't want to be there.
Yeah.
And is in fact super angry at this country for bringing them here or for starting the violence that led to them, having to leave their own country. That doesn't make them any less deserving of services. So the tensions can show up for all sorts of reasons. The welcoming communities are certainly much more common, I believe, in this country than the unwelcoming ones. That's the good news. I think everything I said, I was even just feeling away about some of the things I was saying earlier. I was thinking of these very specific circumstances when talking about the savior complex or the xenophobia. What's much more common is that there are good people all over rural, urban, suburban communities, right? Who just believe that everybody deserves the same things, that everybody should have access to the same resources. And I think that's where, again, Carolyn Chiatto's work, to come back to the beginning of our conversation, feels so helpful to me. When you think about banding together across political identity, right? You're a refugee, you're a citizen, you're, say, maybe an undocumented migrant. Across those political identities, when communities are able to band together to ask for shared resources that they'll all benefit from, then you have solidarity around the identified sort of political ask. You've got advocacy that's bringing people together, and they're all collectively thinking about how they can be uplifted as a group. That's what's really possible in this country. So sort of the happier side of the story is that I think that resistance to being forgotten can be shared, right? And then you have a shared a need, and ask us again, a solidarity that's bringing people together. And it's less important who's the refugee and who's the citizen. And what's more important is how do we all get what we need in this community because it's being underserved. So I love the idea of kind of coming to that story, especially in the current Trump administration, where every single community, no matter who you are, unless you're the 1%, is facing some sort of crisis, like moral crisis, real physical crisis. And we're all having to think about, where do we turn? Who do we look to? And the answer is not the state, the federal government. The answer is the communities around us. And so the degree to which we can erase the political status question and instead come together around the identity of how do we make sure we all belong here, without being naive about it. I think that's where we get the kind of social movement that we're going to need to create the world that gives people access to good health, no matter who they are.
Thank you. Thank you so much. So one thing that has kept coming up, not just in refugee resettlement, but in rural health more broadly, and this is me pivoting a little bit, to talk about rural health, is how easily healthcare get treated as a standalone issue. But really, access to care is shared by so many other things. You've mentioned housing, and then I can throw in transportation, legal status, language that we've talked about, and then trauma and trust. And I know that when you started, you talk about us from looking at this from a right-based lens. So, and I know that's where we are going to, but why is it important that we start seeing refugee health access, you know, as not just delivering a problem, but as a broader equity and policy issue?
Before I answer that question, you know what I want? I want to know your thoughts about that question.
Oh my God. I have so many thoughts. Like, me, when I set up the question, is basically because either I have a mind-boggling, um disturbance around how do we pass these things in different places and then answer them and bring them and couple them together back in a way that makes sense. Because for me, like when we talk about health equity, without looking at it and tied it to right base and just looking at from the framework of what the American system set up, I still see it as the ability for everyone to be able to have equitable healthcare, irrespective of who that is. Like I walk into a primary healthcare center and there's a nurse, there is a laboratory person, right? There's a primary care provider over there. There are basic amenities that they need to provide care to me. And they're not going to be providing care in categorized forms, or because I'm Black, you know, I'm supposed to be treated in certain way because you have a preconceived notion around how Black should receive care, or because I'm white, you have, or because I'm a refugee. So from my own point of view, like those are the things that those are the things that I sit and worry about. Like, how do people just look at a human being and start from there? And I want to hear more from your own perspective as well.
Thank you for that. I'm thinking about specifically around the access to healthcare piece that we're talking about. Much more of the U.S. is rural than urban.
I agree with that.
We've got these huge, huge swaths of land in this country and miles between. And also, the inequity between urban and rural resources is so profound and mind-boggling, to use your word. I'm thinking about Chicago specifically, and the fact that there are not one, but two world-class, multi-billion-dollar children's hospitals within 13 miles of each other. Right? We've got the Comer Hospital in Hyde Park, and you've got Lurie Hospital in downtown Chicago. And they are, again, like world class. Babies can be served in ways there that they can't be served in most parts of the entire world. And then drive yourself 4 hours south to downstate Illinois, and you're not going to find a children's hospital. You're going to find long stretches between community health clinics or hospitals. So one of the benefits to the refugee resettlement process that I described earlier in terms of refugee access to health is that resettlement is not just a destination, right? It's a process. And at the early stage of the process, when there are physical or mental health needs that are severe and require specialized care, that can be identified, right, during the screening processes, because there's a mental health screener that a physical health screener that everyone has to go through before they get on the plane. And they're just not, the State Department had a practice of sending people with significant physical health needs to places that would have the resources to meet those needs. Same thing if you have, cerebral palsy. They're not going to send you to a destination where you won't have access to transportation for a child that has cerebral palsy, right? You'll get access to resources for that child and transportation to go to the doctor to have the resources, to access the resources. So that's one thing I think about. Like if you're someone who just lives in the U.S., who was born here or raised here, you don't get to pick necessarily whether you live in close proximity to a world-class children's hospital. But if you arrive with that presenting need as a refugee, you will get placed near the resource. So that's really cool. However, a lot of physical and mental health needs arise after arrival or weren't diagnosed before or didn't present in the same way. And then you might find yourself in the rural area that doesn't have the kinds of resources that you need, and you are accessing, or rather you're forced to face a lack of access the same way anybody else would, though. So this is where I keep returning to this notion that inequitable access to high quality healthcare, or even just to healthcare and health as a human right, isn't just an issue for refugees. It's an issue for everybody that lives in rural communities that are under-resourced. And in fact, in this case, there may be some subtle benefits to being screened before you arrive, because you will ideally be placed in a place where you have what's called a medical caseworker, right, that deals with those complex medical cases. And I had seen in my own research many examples of the medical caseworker meeting the clients at the airport with an ambulance, taking them directly to the hospital, and the acute need being met on site. So there are some ways that the eligibility for benefits like this for refugees was really working, was really effective. And that's one of the tragedies of the Trump administration ending the resettlement program, because there are people in refugee contexts, as you said, forced migration contexts around the world, who might have been in the queue to come to the U.S. and have their complex medical needs met. And then when Trump ended the program, they weren't able to get on that plane and have their medical needs met. So talk about inequity of healthcare. There's also a global picture and a global story to be told there.
Wow. Thank you very much. I think this is a lot of information that calls for a short break. Do you have a rural health story that needs to be told? Whether you are a health worker, a patient, a policymaker, or an advocate, we want to hear from you. Share your story on our website. Go to www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with details on how to get your story published on our newsletters, website, and other social media platforms. Welcome back. You are still listening to What About Rural Health with Chinasa. And Jessica, I want to shift gear a bit and look at funding structure and how that shape what's possible in social service delivery. And you have written and spoken a lot about performance-based contract, especially in refugee resettlement space. Can you break down how this funding model impacts the day-to-day work of these agencies and how that trickled down to the kind of services and care that they deliver as well?
Sure. And I'll try to make this answer both as uncomplicated as possible, and also focus it on health access, which I don't think will be too difficult. When refugees come to the U.S., again, starting here to think about this before the current Trump administration, the way refugee resettlement has worked since 1980 in the U.S. is that every refugee who arrives is basically associated with a certain allotment of funds from the federal government. Those funds don't go directly into the pocket of the refugee. Those funds go to the Refugee Resettlement Agency. So a portion of the funds go to run the Refugee Resettlement Agency, pay for the caseworker, keep the lights on, if you will. And then a portion is spent on the individual that arrived, renting that apartment I talked about, making sure they have a place to sleep, food in the fridge. So there are federal dollars that are associated with every refugee that arrives. This means that the more refugees that a resettlement agency can serve, the more money they have to pay for staff, right, and the administrative costs and overhead of running that resettlement agency. That's one of the examples of the funding structure. There's a couple different funding structures that are dependent on the clients arriving. And while there's some sense that you only want to pay for services if they're needed, this is an impossible way to run a nonprofit. It's an impossible way to run a nonprofit because you don't, right? I mean, tell me a good way to run a nonprofit, right? This is the lifelong conundrum. However, in this case, if the nonprofit itself doesn't control the flow of clients, they also don't control the flow of funds. So there's an incentive to move your clients through as quickly as possible, get them to reach self-sufficiency as quickly as possible. That's also, to your question, what's being measured. The outputs that are being measured for these refugee resettlement agencies in order for them to renew their contracts include how quickly did you get people to work? Did they or did they not receive health care at work? That's a question. What was their wage? These are the sorts of things that are measured. What's not measured is, did the person get a job they wanted? Did it match the skill sets that they came with, right? Do they feel that their children are happy and healthy? Are their needs being met? Do they belong? These are not things that are being measured. So the sorts of things that are measured are the sorts of things that caseworkers have to spend their time paying attention to, because otherwise the contracts won't be renewed. I am being paid then as a caseworker to get you to work as quickly as possible so I can get the new client in the door as quickly as possible so that my agency can receive as much funding as possible so that when fewer clients come, we have some sort of safety net. So this is the commodification of refugee clients that I think is part of why we see the flaws and in some cases the dehumanization or the flattening of the refugee client and their complex needs when they come in the door. The way you can think about this relating to healthcare is when a client comes in the door and they complain of back pain and the first job available, you have an employer that's eager for 5 people to come load boxes onto U-Haul trucks. If someone complains of back pain, they really do create a problem for you, the caseworker, because you need to get them employed. You have an employer who wants clients. And what you really need is for this person to be healthy, able-bodied, and go to work. And so there are tensions that I think erupt from the driving need of the performance-based contract and what it asks people to focus on as caseworkers, and then the presenting needs of the clients. When those things are in tension with each other, there's a lot of power in being the caseworker who has everything, in their toolbox to really compel that person to go take the job anyway, because the risk of sanction is so high. The risk of losing your benefits is so high when you have the responsibility to work as opposed to just the right. And so that client is likely to ignore their back pain. That the client is likely to comply with what the caseworker wants because the risks of not doing that for their family can be so high. Again, this is not about sort of like evil and malicious caseworker. It's about the incentives of a structure that caseworker is embedded in, and that caseworker also knows if you don't go to work, you could end up homeless. Because that dream you were sold before you got here, where you thought you were going to be living the American dream, it's not real. And the caseworker sometimes knows that more profoundly than the newly arrived person who was told a false bill of goods.
Thank you so much, Jessica, for this response. So as we start to wrap up, and I want to end in a forward-looking note, We've talked about the gaps, the pressure, the politics. But I want to ask you, how can we still move towards more inclusive, right-based care system, even when the broader political environment feels hostile and uncertain right now?
Can I answer honestly?
Yes.
I think we fight for a free Palestine. I think that we fully understand that our souls are bound up in each other's, and that we're not just fighting for equitable health care for refugees. We're fighting for the rights of all people, everywhere, all the time. I think if we really do take in that mindset that any of us who by accident of birth have access to good health care, that it's our responsibility to fight for those that don't. And to me, that means constantly looking for where are the places where the oppression is so profound that if we can at least focus there, if we can make a difference there, then we know we're all better. So that's a free Palestine.
Yeah. Thank you so much for your response. And I agree with you. On that note, it's been a crazy environment, right now. And my hearts go out to everyone in Gaza, everyone also in other places where there are crises and they're being forced to leave their homes and being forced to seek refuge in places that far below what they had put together, they set up to call life. I met a medical doctor who is driving a cab here in the US. This person told me, I had a wife, I had 4 kids, I had my own hospital. I was the director of health before I set up my own private practice. And then war came and destroyed everything. I lost 2 of my kids, I lost my wife, and I'm only here with 2 of my kids that's remaining. And now, a medical doctor, I cannot practice medicine in the US, so I have to drive a cab to subsist. Because sometimes when we don't paint a picture to what these people, this population that we call refugee, you think it's just, hungry people or normal human being who had, basic or minimal life, somewhere suffering, and then suddenly they came to live the American dream. Many of them had the Nigerian dream, had the Palestinian dream, had the Ukrainian dream that they were already living, had the Syrian dream that they were already living, and things happen, and then they are just seeking to survive. So while we hope for the best, I want to encourage our listeners to please engage with this conversation. And also, I want to thank you, Jessica, so much for being here and for bringing these insights, bringing the clarity and the deep care, because I can hear that deep care within your voice of how much this thing means to you. This conversation reminds us that rural health is not just about the system or the services, it's actually about the people, the justice system, and the rights that people have or need to receive support. That is all that matters, actually. So thank you so much for being here. And to our listeners, please subscribe, comment, like, and leave your review if this conversation had a different meaning or made you think differently from the ideas that you already have about refugee and resettlement around the world. Please leave us a comment. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye.